Hey YouTube, it's Marida. Welcome to another edition of the Nurse Lounge. Today we're going to do part 2 of that same lecture that I did just on the other video. I'm dressed the exact same. I just want to go ahead and get this part done so you could watch the second part of this video. If you want to know more about what this video is about, go watch the first one. But for those who don't know me, my name is Dr. Marida P. I'm a registered nurse. I've been a nurse for about almost 16 years. I'm an OB/GYN well baby nurse, nurse educator, and nurse mentor. I am here doing my postpartum lecture for you all in case you all need another perspective on how postpartum nursing is done and what I actually teach my nursing students, as well as what you can potentially teach your patients if you are going to become a postpartum nurse or when you're doing your postpartum teaching. Today is part 2 of this video. I hope you take notes, comment below anything that you think you want to know more about, and I look forward to talking to you at the end of the video. Welcome to part 2 of this 2-section lecture on postpartum nursing. My name is Dr. Marida P. I am the person who's going to narrate or to provide this lecture for you. Again, this is just an alternative to you all trying to find maybe another view or another person teaching this same material to help you better understand postpartum nursing. We're going to pick up from the last video that you watched, and be sure to take some notes, jot down some questions so you can ask those below in the comment section. All right, so we're going to start with talking about the vagina specifically. The vagina is smooth and swollen and has poor tone after you have a baby. Normal tone is restored in about 6 weeks, and the vagina will never return to its nulliparous state. So it never goes back to how it was before having that baby. Kegel exercises is the one thing we teach mom that she should be doing in terms of constricting and relaxing that pelvic floor to help strengthen the tone as well as help with her bladder control. So there is decreased estrogen in the postpartum period. This causes the vaginal wall to thin and to smooth. The rugae will develop within 3 weeks, but will never be in its pre-pregnancy state. And as we just stated, the Kegel exercises will help increase tone. The perineum is typically edematous. The perineum, just in case you don't know, is the area in between the vaginal opening and the rectal opening. That area can be swollen. You can have labial swelling or slight bruising in the vaginal area. This does vary person to person, and someone may have skid marks, which is a superficial bruising, to being extremely edematous and bruised. We like to use the acronym Rita. You should have heard this before if you've already had your postpartum lecture. And Rita is basically redness, edema, ecchymosis, discharge, approximation of sutures. So keep this in mind when it comes to you want to know if your laceration or episiotomy is well approximated and fixed. You should not be able to visualize the sutures. Now, in a normal postpartum area, you're not going to be able to see those sutures. If you put your patient in the lithotomy position, which you should not, lithotomy position means spread eagle. That is the only way you can see those sutures. You spread her completely open, you can see those sutures then, but in a normal assessment, you typically cannot see the sutures, typically. Again, redness, edema, ecchymosis, discharge, and approximation of sutures is what you're assessing when you're looking at that perineal site when it comes to them having lacerations or episiotomies. So what is an episiotomy? The rationale is to prevent overstretching and weakening of the perineal muscles. What are the side effects? Infection, increased pain, longer healing time, and increased discomfort with intercourse. As you can see that diagram, that baby came out and tore that mom in her perineal area. She had to get stitched up down there. She will complain of discomfort after she has this baby. and that discomfort can last up to 6 weeks or longer. You see that the side effects include a longer healing time, so keep that in mind when it comes to things of that nature. When it comes to lacerations, lacerations are classified in degrees, and it is to describe the amount of tissue involved. So that's how they're rated, meaning they're 1st degree, 2nd degree, 3rd degree, or 4th degree laceration. Look those terms up in your book to see what is involved. But again, with perineal lacerations, that's when the body tears along natural lines on its own. Episiotomy is when you were cut. The doctor cut you down there to allow more room for the baby to come out. Episiotomy or a laceration is when your body tore naturally along natural lines due to the stretching in the baby's head coming out. Again, they can be in 1st through 4th degree. As a reference, not that you would need to know this, but for both of my boys, I had 2nd degree lacerations. So the degrees tell you about how much tissue was involved down there. So 2nd degree lacerations, they do hurt. I can tell you that from experience. And when it comes to the healing is about the same. You will have a sensation down there. I tell my patients when they heal, the doctor does have to stitch you up. When you heal, you will itch down there. Keep in mind, everything that heals will itch. So you will find, I tell patients not to scratch down there, but just to use your water bottle to help soothe that area. Use tucks, use your sprays, things like that. You will itch down there when it's healing. That is normal. Hemorrhoids. Many women get hemorrhoids during their pregnancy just due to the pregnancy itself, due to having lower metabolism. So therefore, they're not having bowel movements as often. They have more pressure down there. And obviously during labor from pushing, it's very normal to have hemorrhoids. Women are typically very fearful of that first bowel movement after having a baby. But I tell them they need to go with it when it's time to have a bowel movement, because nothing's going to happen but that stool get larger and larger and larger when you don't go. That first bowel movement is something else. From experience and from what my patients say, it is something else. I tell them to eat well in terms of having fresh fruits, vegetables, drink plenty of water. And of course, we do give them their stool softeners. And be mindful that when it comes to narcotics, a side effect of the narcotic is constipation. That is not going to help the cause when it comes time to have a bowel movement. And so do we push those hemorrhoids back in? No, we don't. We give them their topicals, which is usually witch hazel and or the preparation H type medications. And sometimes if the hemorrhoids are that bad, we give them things like a donut to sit on, and we tell them to use their peri bottles. Those help soothe as well. So now we're going to talk about the breast and breastfeeding and things like that. When it comes to breastfeeding, you should breastfeed immediately after the baby is born. In that golden hour is when we want the baby to be skin to skin with mom, and that's when breastfeeding typically first takes place. If you're not breastfeeding, the engorgement can occur on the 3rd and 4th day. Also, despite what people believe, it is important to start breastfeeding immediately because of the fact that the baby gets that colostrum. Also, your milk does not come into day 3, but we don't wait until day 3 to breastfeed. We want to stimulate the breast to make milk, so therefore we put baby to breast to nurse, even though the baby's only getting that colostrum, which is nutrient rich. It is liquid gold for the baby. We want the baby to have that when they breastfeed. All right, we're going to go into the urinary system. Again, make sure that you go and look in your textbook and your index in terms of urinary system and find out what's very important when it comes to urination and the postpartum diuresis. So what I can tell you is that hormones during pregnancy cause increased renal function. Then after delivery, the renal function decreases and returns to a normal about a month after delivery. Your bladder is also hypotonic during pregnancy. So some women may not completely empty their bladders. The lack of tone persists for 3 months or more. And of course, they're at increased risk of having UTIs. Within 12 hours of delivery, the postpartum woman will begin to lose excess fluid that she accumulated during pregnancy. So this is when you see that especially if you have a C-section, you'll see in their bag, in their Foley bag, catheter bag, that all of a sudden they had maybe 100 or 200 out. I mean, they will always be adequate, but all of a sudden it would pick up and it would turn more of it would be concentrated at first, but then you would see it turn more of a brighter yellow or more clear, shall I say, where it's not the tea-colored urine. It's more like a normal color urine because they are beginning to diurese. The body is saying, we no longer need this fluid, so we're going to get rid of it. And you're going to see them pee more and typically sweat more. They will begin to urinate even more the first 2 to 3 days after delivery. And this also occurs due to decreased estrogen levels is why this happens. But again, your body is saying, hey, I don't need this much fluid anymore. The baby is out and let's go ahead and get back to normal. So therefore, you're going to pee, and usually sweat. And that's when your mom says to you, hey, I'm hot. Is anybody else hot in here? You're like, no, it's just you. It's your hormones. That's normal. All right, bowel evacuation. We kind of alluded to this a little bit when we talked about hemorrhoids. It says spontaneous BM may not occur for 2 to 3 days. I'd give them a week, to be honest with you. If you eaten, eventually it's going to come out. Now, a week is a bit long, but keep in mind that you have to know your patient's normal bowel pattern. So if they were already a 2 to 3 day kind of girl, meaning she does not eat, she eats a lot of processed foods, bowel evacuation is contingent upon your diet as well. Keep that in mind. Your diet is a high indication of when you have bowel movements. It is also during this time that mothers tend to hold their BM because they are afraid of those hemorrhoids, and plus either stitches that they have down there, or they have the anxiety that of course is going to hurt. And so I tell them, like I said before, to definitely go ahead and roll with it. That first bowel movement can be rough, but we want them to definitely go when their body says it's time to go. Again, I was talking about bowel patterns earlier. You have to be mindful that if she has a processed food diet, that she will have bowel movements less frequently. If she has a plant-based diet, she will have bowel movements more often. So you have to be mindful of that when we're doing our patient teaching. All right, so when it comes to your textbook, look up these things in terms of being mindful of what you should find when it comes to cardiovascular system, blood volume, cardiac output, your H&H and WBCs, your neurological system, integumentary system, and your immune system. I will likely do separate videos on these topics so that you will know about what to expect when it comes to WBC and H&H and things like that. I may do a separate video, but for now, definitely write these things down and read in your own text, whatever book you happen to use for maternal, and find out about the cardiovascular, the blood volume, the output, the H&H, WBCs, neurological systems, integumentary systems, and immune systems. All right, so we're gonna go now into those blues and depression and things like that. Find your own where it says it in your book. This is what the pages were in the book that we used. But anyway, postpartum blues usually begin around the 2nd or 3rd day after delivery and usually resolve naturally within 3 to 5 days. Everybody is different when it comes to this. So there's people who it begins immediately and it lasts for 10, up to 6 or 7 days. It lasts for about a week or so. This is due to hormonal changes and it's very normal. I tell moms all the time, they can see that one-eyed dog on TV that they trying to get money for whatever it happens to be, whatever that commercial is, and that will tear her up when it didn't bother her before. That is normal due to hormones and everything else she got going on with her body. She's going to sob about that. There's moms who I'll walk into her room and she's crying. I say, what's wrong? What's going on? Are you in pain? And she's crying, saying she don't know what's wrong with her. They don't know why they're crying. Sometimes they're exhausted. They're sleep deprived. They feel nasty. They got hormone changes. They're bleeding. They don't feel that great. If this is still going on, you want to notify the provider. Now, mind you, if the mom is already having issues with postpartum depression to begin with, then we want to watch for that a little bit sooner. And at our facility, we do what's called a postpartum depression scale. It's the Edinburgh scale that we do on all our moms up on admission to postpartum to see what her risk factors are for developing postpartum depression. We then kind of go into if she scores a 10 or she does say she wants to harm herself, we then take extra measures in terms of calling the doctor and calling case management. So your usual symptoms of postpartum blues is your mood swings, your anger, and your sadness. This is very much normal. This is not bipolar. This is very much normal how they can be, very emotional, and they don't have an idea as to why half the time. Postpartum depression is when we range from mild to severe and it may appear gradually. Symptoms are present for more than 2 weeks, and we treat with medication, psychotherapy, or both. So when it comes to the medication, we treat them with the same medications you treat depression with. Keep in mind that a lot of these medications you cannot breastfeed on, so we need to find out what mom's intentions are and basically govern ourselves to be the lesser of the two evils. Yes, we want her to breastfeed, but at the same time, we need her mental state to be intact. And so therefore, the best bet for the baby and the mom is to bottle feed if that's the case. So when it comes to the postpartum nursing assessment, what do you need to know? The postpartum assessment should detect any deviation from normal. Now, mind you, if you've seen my other video, which I'll try to link that to, we talked about the bubble her assessment and what that means. So I won't spend a whole lot of time in it here, but I do want you to go look at that assessment video that says postpartum assessment bubble her. That will go through this in great detail, but I will spend a little bit of time kind of going through a few things. Actually, I've talked about a lot of these things already. I've talked about the breast, the uterus, the bowel, the bladder, the lochia. I've actually talked about all these things except for the emotions in great detail, but just be mindful that I do have a whole video dedicated to the bubble her acronym, and I definitely recommend you watch that video. I will try to link it below so that you will be able to watch that video as well. All right, postpartum education. As you know, I did a whole video on this as well. When it comes to postpartum complications, I'm going to do an actual video on that specifically. Teaching about episiotomy and care of stitches. We talked about that already. When it comes to, she needs to make sure she's wiping from front to back. She needs to make sure that she is using a topical, using some type of spray, witch hazel for those stitches, that she does not need to scratch or try to pull out those stitches, things like that. And then obviously when it comes to postpartum education, believe it or not, the newborn care is also in that, but that is more of a different topic, and I will cover that in another video. Nursing care and teaching. When it comes to the perineal area specifically, you want to talk about hand washing, which the mom should be washing her hands before she touches herself and after she cleans herself. The peri bottles we use to put the warm water in to spray or rinse off her perineal area. We want her to pat from front to back, not per se wipe, because if she has stitches, she's not going to like that. Make sure she changes those peri pads every 2 to 3 hours. We give them ice packs for swelling and for pain down there. We do offer sitz baths. We've already talked about Kegel exercises, and we talk about evaluating pain and using pharmacological as well as non-pharmacological methods such as your peri pads, not peri pads, your ice packs, your perineal bottle, things like that. So when it comes to specifically the uterus itself and the fundal exam, how do we do that? So basically you're going to take one hand, as you can see in the diagram, and you're going to support her on her mons area, applying pressure while you're actually pushing in on that uterus, trying to find out what the placement is. Is it at the umbilicus, one below the umbilicus, two below? And we're talking about one or two below. We're talking about finger breadths below. And mind you, that is slightly subjective because we have different size hands. So you may want to look in whatever your textbook is and type in or look in the index and find fundal exam and see how they're telling you to do it. But that's just an example. Plus, I did talk about this in the Bubble Her postpartum assessment video. So again, I will try to link that below. When it comes to the perineum and how we look at the perineum, we want the patient to assume the Sims position. So whether that be left lateral Sims, but we want them in the Sims position so that we can appropriately see the perineum and we can assess accordingly to the Rita, whatever it's called. So you're going to have them lay on their side and you're going to have one leg extended and they lift up the other leg. You'll have gloves on and you will check the perineal area from the back. And while you're back there, go ahead and check the rectal area for hemorrhoids. That's when we do that as well at the same time. And we want them to, we're checking for redness, edema, ecchymosis, discharge, and approximation of sutures, just as a reminder. All right, this is kind of going over the Bubble Her. I'm going to go through this real quick. But again, if you want further detail, then you want to go to that other video. But we're palpating the breast for firmness. We want to observe the nipples for cracking or other potential problems. I typically tell people when I'm listening to the heart sounds and lung sounds with my stethoscope, the base of my hand naturally fall on her breast tissue. And this is kind of how I'm feeling for the firmness and things like that. We want to teach her about her breast care and her breastfeeding. That's more of a nurturing thing in terms of breastfeeding itself, unless you do couplet care. At our facility, we have lactation and we have nursery nurses that handle that. As a postpartum nurse, I do not handle that. When it comes to the breast care, I do talk about breast care. I do provide, we use lanolin at our hospital to put on the patient's nipples or for them to put on their nipples before breastfeeding. Lanolin is basically like a chapstick for the nipples, is what I say. I tell patients it's like chapstick for the nipples. And it's helped to prevent soreness, cracking, things like that. The same thing that chapstick does for your lips is what it does for the nipples. And they do not have to wipe it off prior to breastfeeding the next time. Rest. How important is it for our patients to have rest? It's of paramount importance. So many factors affect rest, such as the social, financial, infant temperament, family situations, and support. Is what that says under the picture. The picture somehow shifted when I changed the PowerPoint background. So that's why you are seeing some pictures over words, is because of the PowerPoint background I changed. And that's what it says though. Many factors affect rest, which are social, financial, infant temperament, family situation, and the last word is support. So what are we doing as a nurse? We are asking our visitors to leave. There's nothing wrong with that. You are managing patient's care. So when you manage the patient's care and you see your patient's blood pressure going up, you want to be mindful of that and say, you know what, she needs to rest. Or you see her getting agitated, you see her crying, you see things going on that your patient is not happy. And if it's something you can help, you want them to rest. So therefore, we encourage that. I will say, due to the COVID situation, when we only had one visitor, our patients seemed to rest much, much better. Their pain was better controlled, and they were in much better moods because they were allowed to sleep more because they didn't have to entertain as much company, so to speak. So ask visitors to leave. Don't have a problem doing that, and have a conversation with your patient if you need to, that I may have to ask your patients to leave if your blood pressure continues to go up. So providing rest periods, which means when we as nurses, when you go in, we want to cluster our care. You don't go in there every hour for something. Now, mind you, some hospitals require that you do hourly rounds during the day and every 2 hours at night. If that's what your hospital requires you to do, that's something different. But I still try my best to cluster my care when it comes to that, where I'll say, I'm going to do everything. If I have something to do at 12 and at 2, 12 and at 1, I'm going to do it all at 1:30 so I can minimize how many times I come into the patient's room. So we want to provide them with rest periods, and you want them to sleep when the baby sleeps. So if you have a nursery or somewhere like that that allows the baby to go to the nursery or allows a break for mom, then definitely encourage her to utilize that so she can get some rest from time to time. She should still be bonding with her baby, feeding her baby, changing her baby's diapers. I'm not saying that you have to do everything for mom, but I am saying allow her adequate time to rest. It allows her to be recharged. It keeps her blood pressure and heart rate in check. And obviously it helps with her pain and makes her feel better. So when it comes to ambulation, as you all know as nurses or nursing students, early ambulation is always the best for any kind of patient. So when it comes to early ambulation, we want to make sure that we have our patients walk as soon as they can after delivery. Now, when it comes to our C-section patients, they cannot walk immediately after delivery. They walk usually within so many hours of delivery. And so for us, it's between 8 to 12 hours we get them up with assistance. And at that point in time, we encourage them to continue to walk the halls, the room, things like that. The more they walk, the sooner they're able to go to the bathroom. Keep in mind, the more movement you have, peristalsis then occurs, it increases and causes that air to move through as well as that food to move through, which allows you to get moving, not only literally, but also bowel elimination wise as well. Keep in mind, a sedentary lifestyle, you don't go to the bathroom as often. The more you up move, the more you go. Peristalsis, remember that. All right, nutrition. When it comes to nutrition, we want protein and vitamin C to promote healing. Protein is in foods such as eggs, meat, peanut butter, things like that. Protein shakes. Vitamin C is in your citrus type things. You want your moms to be eating these things. Also, it promotes wound healing. If she had a C-section, that will help promote her wound healing. You need to know that lactating mothers are higher than for non-lactating mothers. So therefore, they also require extra calories. Typically, only 300 calories extra is what they require. However, that's nothing more than maybe an apple or so, but they need extra good nutrition, not an extra candy bar, chips, but good nutrition. And then be aware of cultural dietary preferences, things that they cannot eat. Knowing cultural standards when it comes to foods is very important in your postpartum care of your patient. All right, let's talk about pain medication. So when it comes to pain medication, we want to be mindful of afterbirth pains. We talked about that earlier. Afterbirth pains are very normal phenomena when it comes to having a baby. We typically give some type of analgesic. Well, it says 15 to 30 minutes before breastfeeding. Keep in mind, if you can give it. But if it's scheduled or something that she can't have because she just recently had some, it may not line up accordingly. But definitely give her medication when she's able to have it. You want her to empty her bladder. If she empties her bladder, it also cuts down on those contractions because her bladder is not full. And then heat to the abdomen. Keep in mind, I mentioned in a video that you haven't seen yet, but heat to the abdomen may mean like a heating pack, a K-pad, things like that. Do not be in the habit of actually making those heating packs where you wet a towel in warm water and then you microwave it for so many minutes and then you wrap it up. Don't do that. That's against the law, illegal, get you fired if you burn that patient. So if your place has heating packs that you break and they heat up, give them that. If not, see if your hospital has what's called K-pads that are actually admissible, that has a temperature gauge on it, so you'll know exactly what you are, the temperature of the heating pack, so you'll know what's going on with your patient. Bowel elimination, we talked about a little bit already. You want to encourage ambulation. We want a high fiber diet. So we're talking about things like vegetables and fruits and grains, things to help you go to the bathroom. We want her to increase her fluid intake to at least 8 to 10 glasses of water, preferably. We want stool softeners that we actually give our patients usually 2 to 3 times a day. And then you want to keep in mind, we talked about this, narcotics contained codeine should be avoided. Basically, that these things cause constipation. So these are not going to help her go to the bathroom, but it's going to prohibit or make it more uncomfortable for her to go. You have your patients who like to take their narcotics every 4 hours and then complain that they can't go poop. You can't poop when you're going to take narcotics every 4 hours. It's going to be hard. It's going to be difficult to pass, and you may have to bear down, and you don't want to do that, especially if you have stitches or hemorrhoids. I'm sorry, this is a little bit off, but when it comes to urinary elimination, within 4 to 6 hours, you should have the patient should have the urge to void. We want to make sure that we actually try for our patients to go void within the first 2 hours. And then we encourage them to go void every 2 to 3 hours after the fact. We want them to have adequate fluid intake. And let's not use the word adequate. I should have changed that. Adequate doesn't mean anything to me, because adequate to me may mean 1 cup of water, where adequate to you means 2,000 mLs a day. So let's stick with the 8 to 10 glasses a day is what we need to try to push her to drink. We want to make sure that, it says give analgesia 15 to 20 minutes before. Okay, that's not always possible because you have to time it just right. And they go to the bathroom at some point so often, you can't give it every 15 to 20 minutes before. Be mindful of your medication times and dosages. Warm water over the perineum. So that is like using your peri bottle and spraying that warm water. Sometimes that helps them go to the bathroom. Turn on tap water. So these are some tricks to the trade in terms of helping her go to the bathroom when she feels like she can't go. I've actually had patients who they couldn't go on a toilet, but once we got them in the shower, they were able to pee in the shower. Now, mind you, I could not collect it in terms of a measured void, but I did know that she did pee. So then the next time I know she could go. So the next time I measured her urine at that point in time. Again, that trick is not for you to use on a test. That's not a appropriate test answer. I'm just saying that's tricks to the trade where I've had them pee in the shower because that's what I needed for them to do. I just needed you to pee. I can capture the next one. Privacy and do not rush her. Some people can't go to the bathroom with people sitting looking at them. Now, mind you, if there's not a safety issue, you're not afraid of her falling or being dizzy, then push the door up and let her do her business. I have stayed in the room, but pushed the door up where I didn't per se just sit there and look at her. And that have allowed them to go pee as well. All right, we've already talked about this, but I'm going to hit the highlights on this in terms of sitz baths and hemorrhoid care. Hemorrhoids, you can use a sitz bath. You need to avoid prolonged sitting positions. I've never used ice on a hemorrhoid, but maybe that's what some people do. Sprays like your Dermaplast spray and Tux. We want to have them increase their fluid intake, which we talked about. That's 8 to 10 per day. Fiber in their diet, adequate rest and exercise, and stool softeners. Now, mind you, in the hospital, you're not going to be doing no exercise or nothing like that. But we're talking about going home in that situation where she is in a more so normal routine and she's able to exercise to a certain degree. All right, so these are some of the vaccines we tend to give our moms. We give them rubella. If they have not had the MMR or they come back to be equivocal, as an example, then they are a candidate to get the MMR for the rubella component. It is a live virus, so we typically give that right before they go home. And there is a 2 to 3 month waiting period before you can get pregnant. So because it's a live virus, we do not want them getting pregnant in the immediate postpartum period anyway. So I tell them this when they're getting their vaccine, if they choose to get it, that you cannot get pregnant for the next really 90 days to be safe. That's what we tell our patients. Keep in mind that rubella is part of routine pregnancy labs. If she is determined to be non-immune, it's recommended that she does get this prior to discharge. Some contraindications for getting this is if she is immunocompromised or she has an egg allergy. It is it is a live virus, but it is safe for breastfeeding moms. So that is the number one question of all medications. Is it safe for me to breastfeed and get that vaccine? The answer is yes. You can breastfeed and have this vaccine. All right, now we want to talk about RhoGAM. So we give this RhoGAM, the Rh immune globulin. We give this RhoGAM, as we call it, to moms who are Rh negative. So let's just say and the baby is Rh positive. So what that basically means is if she is AB, or O negative, but baby is AB, or O positive, she gets this injection within 72 hours of delivery. Of delivery. So we typically give this on day 1 or 2 after she's had her baby, once the baby's blood type comes back as positive or negative. If the baby is Rh negative as well, mom does not get a injection. If mom is negative, baby is positive, like I just described, she will definitely get this prior to discharge. And basically what it is our body will naturally reject anything that is not of us. We give this to Rh negative moms who have Rh positive babies so that her body does not reject the next baby. It has nothing to do with the one she just had today. It's so she does not reject the next baby. So keep that in mind. Her body doesn't reject the next baby. All right, so other topics to teach mom. Sexual activity. So find sexual activity in your index and read what it says about that. But basically it's like this. She should not be having any sexual activity for at least 6 weeks. She needs to have pelvic rest for the next 6 weeks. She's bleeding anyway. Now, I will say this. I tell my moms all the time, why do you all think people come back pregnant at the 6-week checkup? They come back pregnant because they did not wait the 6 weeks. So I tell my moms and dads, if you are going to be sexually active, you need to use some type of contraception, some type of barrier method. So she needs to have either the female condoms, a spermicide, obviously the male condoms. Some people do get Depo prior to discharge at the hospital. But for the rest of us, the rest of the people, they should be abstaining from sexual intercourse anyway. But again, let's be real. I'm always telling my patients, if you're going to try it out, make sure you have some type of contraception on board unless you are wanting to be pregnant within 6 weeks. We want to go over with her prescribed medications that she's going home with, her prescriptions. So you want to make sure you talk about that she's going to get Colace or Motrin or some type of narcotic, what those side effects are. It should not be brand new to her because you should have been talking about these medications and topics and treatments all during her postpartum stay. So it should be just a recap of what she already knows. It should not be a whole full-fledged lesson at that point in time or teaching topic because you should have already taught that. We want to talk about her routine checkups. So within a 6-week period of time, mom should have already went back to the doctor for a postpartum checkup if she is a vaginal delivery. For C-sections, they typically go back within a few days to a couple of weeks to get their incision looked at. Then they'll come back again within 6 weeks for their actual postpartum checkup and to be released from OB and begin back with their primary care physician or PCP. Activities of daily living. Basically, we tell them that they can progress as they want to progress, meaning that as they're feeling better, getting their energy back, that they can do what they want to do. We don't encourage them to drive if they don't have to. We tell them not to drive under the influence of narcotics. We tell them that, delegate household activities to other people. Don't try to be super mom and going back home with a new baby, trying to clean, cook, dishes and stuff like that. Them dishes can either sit there or dad can do it. Or if people say, hey, how can I help you? Have them come over and do some housework for you. Or have them fix some casseroles and some dinners for the family so that you don't have to cook for a while. When it comes to visitors, you want your visitors to be at a minimum to a certain degree because you don't want to expose anything to a new baby and to a mom who's just had a baby. So I tell people to keep their visitors to a minimum, to make sure that they do proper hand hygiene or use hand sanitizer. You don't want smokers at your house. You don't want people who are using drugs at your house knowingly. You don't want alcoholics at your house handling your baby. So keep your visitors to a minimum if possible. When it comes to menstrual cycles, this will return usually within a month or so. If you're breastfeeding, you may not have a cycle for who knows how long. That does not work for everyone, but for some people, if they breastfeed, they do not have a menstrual cycle until they stop breastfeeding. For other women, not so lucky, they start bleeding within a month to 6 weeks after having the baby, and then their cycles continue from that point on. I do tell moms to expect the first cycle or maybe the first few cycles to be very heavy and their cramps to be much, much worse. And speaking of cramps, I forgot to mention this under afterbirth pains. The more babies you have, the mom has, the worse her cramps are. So when she says to you, oh, my cramps seem so much worse than they were the last time, you check and see how many babies she's had. If she's had 5 babies, the cramps are going to be that much worse every time. When the next baby comes, if she has more, it's going to be even worse. So tell her when it comes to her cramping that it's very normal to have cramps and it to be worse and worse each baby that she has. And I tell them That why is that? I teach my patients quite a lot. The reason why your cramps are worse and worse each time after having a baby is because of the fact that the uterus is a muscle and that uterus has been stretched however many times. So if your uterus has been stretched 5 or 6 times because you've had 5 or 6 babies, that uterus has to work extra hard to get back to its pre-pregnancy state. So it is working harder and harder and harder. Think about someone who has gained weight and you keep gaining weight for whatever reason. You lose weight, you gain weight, you lose weight, you gain weight. Every time you do that, you have to work extra harder in terms of making sure that you're eating better, doing more exercises to get back to the way you were before. That is what the uterus has to do because it is a muscle that requires work. And because it's been stretched out so many times, it's trying to work to get back to its pre-pregnancy state. So it contracts down even harder each time. All right, so look at your book where you look in your index and find the transition to parenthood, which is the dependent, independent, and interdependent. So when it comes to dependent, which is taking in, it usually begins, I'm going to kind of go over it with you a little bit, but you want to read in your books, whatever books you're using for this, when it comes to what it says. But basically, the taking in stage begins in the first 24 hours and lasts 1 to 2 days. The mother's focus is on herself and meeting her own basic needs. They desire to review the experience of the birth. So basically, you have your mom, you go into their room and they talking to family members about what happened. Oh yeah, I had the baby here and oh, I got stitches and the baby wouldn't come out at first, but I pushed this many times and she's beautiful. She looks like this. They're talking about their whole experience. That is the taking in stage of transitioning to parenthood. Then the independent is taking hold. And that is basically starts in day 2 to 3 and lasts about 10 days to 2 weeks. And her focus is the care of the baby, and mom wants to take charge. She knows this is her new role, or her new role again if she has other children. She is wanting to now focus her time and attention on making sure the baby's needs are met, feeding the baby, grasping and learning about breastfeeding. She's getting back into her role as mother, wife, girlfriend. She's now beginning to come up with a schedule. She's taking hold of the responsibilities of what she has in terms of parenthood. And she is now not as much talking about anymore about, what happened unless it comes up. She's more talking about her current role in this process. And then interdependent is letting go. Letting go means we're going to move forward as a family unit. Now we are renewing our relationship with a partner. So letting go means, okay, now that we have the new baby in our family, how do we now go back to normalcy, including the new baby? So she is now at a point where maybe dad has went back to work, but dad has been feeling neglected because all of the time has been spent on the new baby. So now she is back with her partner. She is, talking to him more, engaging with him more. He is more of a companion and a help than go do this, go do that, go do this. He is now involved, or she is now involved if it's a same-sex couple. And that's kind of what they're doing. So she is now trying to move forward as a family unit, incorporating the baby and the partner and the other children, if there are other children, and believe it or not, pets. Pets are also very important because a lot of times pets have to be introduced to the new baby smell and things like that. So that is also a component into bringing pets into that family unit. And then this is the very last slide, which is parental grief. We talk about this in a way that is very difficult. Everything when it comes to having a baby does not sit well, meaning that she came in to have a baby, or maybe came in for something and the baby was a stillbirth. The baby, she lost the pregnancy or the death of the infant. So maybe it wasn't born deceased, but it died shortly thereafter. And you're going to have to go through those stages with mom. She's going to be in shock, denial. She will have intense outbursts of emotion. Sometimes they lack affect or they're trance-like state. And you have to kind of know what to do and how to do it based on your hospital's policy when it comes to those different things. There's typically a little icon or a little thing, a little not sticker or something that you put that there's been a loss of a baby in a room, so that you don't go in there, or somebody in the nursery doesn't go in there, or somebody doesn't go in there saying, hey, where's your baby, when she lost her baby. There's usually some type of icon of some sort that say this is a baby lost in this room, so don't go in there asking about a baby. Decisions are to be made. This is for the family to be doing, and regarding funeral homes, regarding cremation, regarding a grief packet where they get pictures of baby, hair of the baby, pictures, they hold the baby. So this is normal. And I, as a nurse, have dealt with parental grief. It is very difficult to deal with. As a nurse working, you do not want to have, if possible, a pregnant nurse caring for this mom. If at all possible, you do not want that. Moms go through a lot when it comes to losing their baby, and the last thing they need to see is somebody else who's pregnant. Also, when it comes to parental grief, we want to keep them either off that unit or on a part of the unit that there are no other moms around. So we have an area on our floor that we use all the time, but if we can put mom back there by herself, we will. And we will not put a mom in the room next to her with a baby, or we won't put on either side of her. We won't put moms in that room with babies, because she can hear those babies crying through the wall. So we take extra precautions like that as well. And very seldom do we just send them to another floor. Depending on how early the mom lost the baby, let's say she lost the baby at 19 weeks, it wasn't viable anyway, her bleeding's under control, they will typically keep her in labor and delivery and let her stay over there for a few hours for her recovery. And if she seems to be stable, they will send her home from labor and delivery. She does not stay that long. Typically, she doesn't stay a whole day. She only stays for a few hours after delivery of the baby, just to make sure that her bleeding's under control. They give her very thorough postpartum teaching in terms of caring for herself, when to come back if need be. But that is something we have to deal with also. Every day is not a good day in the OB world. So again, decisions have to be made. And what is the application of the nursing process when it comes to parental grief? You want to go ahead and review those things as well. This concludes the lecture that I typically do for my students when it comes to postpartum nursing. If you have any questions or concerns, please comment those below. I'd be happy to read through them and answer them for you. Hopefully that video was good for you, and these videos, part 1 and now part 2, has been insightful for you in terms of helping you understand what the postpartum process is like. This is what I teach nursing students. This is what I govern myself accordingly by when I actually take care of my patients. Hopefully this has been insightful for you and helped you in your nursing journey. I wish you all well in terms of you being postpartum nurses, or if you're coming over from another unit, you used to be a mother med-surg nurse or something like that, and you're coming into postpartum, welcome to postpartum. But hopefully, again, this has been insightful for you. I love doing these videos, and I want you to comment, like, share, subscribe to this channel for more nursing content and other content, but primarily nursing. Also, follow me on IG. The handle will be here or here, as well as in the banner at the top of my YouTube page, as well as in the description box below. You will see my IG page. I am more than just a nurse educator. I'm also a mom. I'm also a lover of doing all things fun and getting out and doing fun stuff. That page is the Nurse Lounge over there as well. MelaninRN_NPN is the page. Follow me over there. And I look forward to definitely working with you all in the future. If you happen to need a tutor, that is something that I do as well. I am a tutor. If you're in your pre-nursing courses and you're looking for someone to tutor you in your A&P, that can be done. Again, it is something that I charge for my time and my expertise. I've been a nurse for 16 years, so I've been doing this for quite some time now. If you're concerned about how to go about doing that, you're going to simply send me an email, which I will also have in the box below, and you will simply tell me what your needs are. We work out the payment arrangements, and it is done via Zoom. So that is free for you, and it makes it where we can do our sessions, hour-long sessions, conveniently. No matter where you live in the world, I can do that via Zoom for you. Anyway, thank you so much. I keep rambling on this video. Thank you so much. It's been long enough. I truly appreciate you all. This has been wonderful, and I'll catch you all in the next video. Bye-bye.